Good evening, everyone. It is my pleasure to introduce our guest speaker tonight. Mr. Conway is a senior fellow at the Institute for Healthcare Improvement and a senior consultant at the Dana-Farber Cancer Institute in Boston, Massachusetts. From 1995 to 2005, Mr. Conway served as Executive Vice President and Chief Operating Officer of Dana-Farber. His areas of expertise and interest include patient safety, patient and family orientated care, and healthcare change management. Mr. Conway has brought to Dana-Farber Cancer Institute after a highly publicized avoidable death of a patient. Under his leadership, Dana-Farber completely overhauled its approach to patient safety. Key to that approach was a drive for public transparency and a thorough transformation towards a patient-centered approach to care. The model pioneered at Dana-Farber is being implemented at hospitals across the U.S. and Canada, including right here at HSN. Patient-centered care and patient safety are pillars of our new strategic plan, which we publicly unveiled last week. It is HSN's great honor to have Mr. Conway here with us today. Please welcome James Conway.
Well, thank you very much, Michael. It is an amazing honor to be in your community, and I think through your efforts over the last 24 hours, I feel like I've met most of the community, and we've had exceptional conversations with the medical staff, with senior leadership, with the management of the organization, with patients and families, with the governing board, all in service of this extraordinary privilege we have, which is service to patients, families, public, and the community. I'm going to go through a lot of stuff in a short period of time. My email address is there for you. I am indebted to you, to the province of Ontario, to Canada for all that I've learned over my years working in this space, and anything I can do to give back, I absolutely want to do. So what we're going to talk about today is an extraordinary journey, as was noted, of the Dana-Farber Cancer Institute after exceptional tragedy. But before we jump into that, I want to do a bit of a prologue just to define what's this thing we're talking about called patient and family-centered care, and why, how did I, as a healthcare executive, become fanatic in the area of patient and family-centered care? Why would I, as a leader, talk about the power and privilege of patient and family-centered care? After we talk about the Dana-Farber story, we then will talk about some very specific requests that I've had. So how did we set expectations? How did we position people for success? How did we move this from talking about it to doing it? What are some of the challenges? If people said there weren't challenges, they'd be lying. There were a lot of challenges associated with this. And then what at the end of the day were the outcomes? First, though, I want to begin with a statement of congratulations. I've read your strategic plan that's just come out. I've read your plans and reports from prior years. For the last 2 years, I sat on a committee of the Institute of Medicine of the United States. It's an independent arm of the US Congress, which is asked to probe challenging issues. And one of the issues we were asked to probe was how in America do we build a high-quality health system at lower cost. Our report was issued in September. I'll touch on it at the end. And it's receiving exceptional pickup. As I read your strategic plan, and I compared it with what we learned at the IOM committee, there is extraordinary resonance between our recommendations and the recommendations of you and your community. I also am very impressed with the progress that you're making in a very short period of time in activating the power and privilege of patient and family-centered care. So the prologue, what's this thing called patient and family-centered care? I use this first definition because it was one of the earliest definitions of patients and family-centered care. As I read the elements of this definition, think of the care that you receive. Think of the care that you want your kids, your spouse, your parents to receive. It's care that respects patients' values. It honors their preferences. It's care that worries about coordination and integration. I have a chronic illness. What I'm learning, and I have privileged access, as you move across the care system, it often can be extraordinarily bumpy. How do we design that care so it is continuous across it? How do we provide information, communication, and education? Many of you have been fascinated to hear that as a patient of the Beth Israel Deaconess Hospital in Massachusetts, for the last 10 years, I've had access online to my medical record. We could all go online to my record, check my last visit note, check my last lab results and reports. So how are we providing me, the patient, and the patient's spouse and family with the information and communication and education? Are we providing physical comfort? Are we providing emotional support? I just recently gave a talk on patient and family-centered care at McLean Hospital. That's the psychiatric hospital for the Harvard system. After that, I met with family members of people who were in residence at McLean. And I was sobered at the complexity of the system when behavioral health or mental health is introduced in the equation. It's about involvement of family and friends. It's about transition and continuity and ultimately access to care. Well, the definition I've used in my career and we've used at the Dana-Farber came out of the Institute for Now Patient and Family-Centered Care. It says it's patient and family-centered care. The work that you've committed to as a community is first grounded in dignity and respect. Providers listen and honor patient and family perspectives and choices. The second, as we talked about, is its ground in information sharing. Providers share complete and unbiased information in ways that is affirming and useful. I've told many of you about my friend Carol. Carol Levine's an amazing woman, a healthcare executive in New York. Her husband, in a tragic accident 18 years ago, was neurologically devastated. And Carol wanted her husband to stay in the home with her as much as she could. She would say to me, Jim, it's Wednesday night, we're in the ICU, there's 40 people taking care of him. Friday night, we're in the med-surg unit, there's 10 people. Saturday night, we're in the hospital bed in the dining room. It's just me and him. How have we engaged and partnered with Carol in a way that she is able to care for her husband in a way that honors their relationship and respect him? It's all about participation in care and decision-making. I've shared that I am a diabetic. One of my colleagues I've met over the years is Lord Nigel Crisp, who used to run the UK health system. And Nigel told me that based on studies in England, that if I have a course of a typical diabetic, that 80 to 90% of the care I receive in my lifetime, I'll receive in my bathroom, my kitchen, and my bedroom. So it's understanding the privileged relationship and partnership that exists between my care team, but also what goes on at my home. At the end of the day, whether or not I am a good diabetic or a bad diabetic will be based on the choices that I make, informed by my team. And it's a lot about collaboration in policy and practice, and we're going to talk about that some more. So how did this exec become crazed in the area of patient and family-centered care? In the 1970s, I was working at Children's Hospital in Boston. Mothers, after winning a major victory for special education for their children with significant disabilities, turned on health care. And they began to say, remember in the polio epidemic in the 50s, a parent was able to see their child in an iron lung once a week. In the 70s, parents were not allowed to stay overnight in the hospital with their children. Mothers began to say, I don't care who you are, I'm not leaving. I discovered that there's no force in the world stronger than a mother in my face, periodically a dad, but most of the time mothers advocating for their kids. And I also discovered that just because somebody's poor doesn't mean that they're stupid. And at Children's Hospital, we discovered, with some provocation by our patients and family members, the extraordinary power of partnership with children, with teenagers, and with adults around care. In 1995, I was recruited to go to the Dana-Farber Cancer Institute. Dana-Farber was founded in 1947, relatively new. It was the premier U.S. comprehensive cancer center, one of the original 7 designated by President Nixon. We provided adult care, pediatric care, had a huge research agenda, and were the primary cancer teaching affiliate of Harvard Medical School. We were also the home of the most popular fundraising charity in New England called the Jimmy Fund. Well, in 1994, an abysmal tragedy happened at Dana-Farber. We discovered that we had administered a 4-fold chemotherapy overdose to one of our patients. We didn't discover it at the time of death. We discovered it 3 months later when a clerk, loading some data into a computer program, noticed a level of chemo that she had never seen before, and she gave us a gift. The gift was she saw something and she said something. And what Diane helped us to discover is the burden that we had killed, and I use that word intentionally, killed, Betsy Lehman, the wife of one of our cancer researchers and the Boston Globe health reporter. We also had ignored her voice. Betsy, in the weeks before her death, was saying that she was having an atypical response, but she was just the patient. What did she know? And we did not honor the voice of the patient in adult care. We devastated her family, friends, and our staff. The last thing our staff wanted to do was hurt somebody, and we failed in our mission to community. So, led by our governing board, the organization made a decision to disclose, knowing that all hell would break loose, and it did. But in our responsibility to the patient, it was the only course to go. Our responsibility was to assure would never again, with the failure of our systems, kill a patient under our watch. And we committed to relentless improvement, relentless PDSA cycles until we made sure that was happening. Well, what were the key levers of this journey? The first is the exquisite responsibility of leadership.
Dr. Shukla, please call 4980. Dr. Shukla, 4980.
The exquisite responsibility of leadership at all levels to drive quality and safety. The second was the relentless vigilance. Healthcare is a high-risk enterprise. The relentless vigilance every day to safety, risk, error, near miss, and harm. A friend of mine, Ross Baker, your Ross Baker, has estimated that 7% of Canadians have adverse events during their inpatient hospitalization. We then also learned that we had to address the multiple victims of error. That's not only the patient and family, it's also the staff, the doctors, the nurses, the pharmacists, and everybody else. And the community that was devastated by this. We then learned also the importance of putting in place systems that supported safe practice. I came up with a mantra that I said 1,000 times, and I thought people were sick of it. And when I left Dana-Farber 10 years later, the nursing department engraved part of it on a chair and presented me with the chair. The mantra is, our systems are too complex to expect merely extraordinary people to perform perfectly 100% of the time. Leaders have an absolute responsibility to put in place systems to support safe practice. No matter how good you are, and you wouldn't be here if you weren't good for the hospital staff, you suffer from being human, you are going to make mistakes, and we have an absolute responsibility to make sure that your humanness doesn't get to patients and cause harm. And then the final two levers, the first was the synergy of interdisciplinary practice, and the final was patient and family-centered care. We also learned that we had to set expectations. Until you set an expectation, deviance can't stand out. Anything goes. We had to position people for success, and we had to hold them accountable. So in 1996, our governing board made patient and family-centered care a priority, and with the understanding that patients and families would populate all decision-making bodies and structures of the organization. If we were talking about care, we couldn't have that conversation without patients, the public, the community in the room. Well, what are some of the strategies we used to drive this forward? The first was the clarity of expectation at the governing board and the executive level. I have been so impressed as I've met with senior leadership on the clarity of that expectation. It was engaging the board in leadership. It was making sure that we weren't developing a new silo, an elegant silo. It was integrating it across the organization. It was making sure that we listened. This was scary. Real good docs, nurses, pharmacists, receptionists all had concerns. It was listening their concerns, coaching and training them to do this, pacing and worrying about quick wins and not going crazy. It was celebrating major milestones, providing support, and modeling it from the top. It was at every level of leadership saying, this is important to me. So I'm not going to go through this. So when I say patients and families were involved in every decision of the organization, this was where we had been after 5 years. If we were involved in redesign, there was not an aspect of redesign that patients and families weren't involved with, starting with governance. Well, what were some of the challenges? Some of the challenges, a lot of people thought this was just PR. It was public relations. It was nice but not necessary. We were struck that patients, the public, our staff are in very different places. Some people are, let's go, and other people is, woo. And we had to respect those different places. People were petrified of the unknown because they hadn't done it before. They hadn't been trained. Many clinicians felt that they already knew what patients and families wanted. I've been working in pediatrics for 30 years. I know. One of the most unbelievably sobering things we found is we don't. The only people who really understand how well we do are the people closest to the work, frontline staff and patients and families. Some people thought they'd be in the way. Others thought that they would be devastated because patients would find out that we weren't as good as we said we were. Well, patients already knew that we weren't as good as we said we were. We had to shut up and learn to listen, ask questions, and then learn to listen, and we struggled with embracing diversity. But with all of that, what were the positive outcomes? If you go to Dana-Farber today, almost 20 years after we began, the sense of institutional pride in our patient and family-centered care work is electric. What we discovered is the stuff that's driving patients crazy is also the stuff that's driving staff crazy. They became invaluable in helping us prioritize improvement. As I may have said already, I forget. If you try to accomplish everything, you will accomplish nothing. And one of the biggest skills we have to develop is how do we prioritize. They helped us improve outcomes. They were masters of partnership. We got unbelievable external recognition. So I've talked about our journey at the House of Commons. I've been at Moscow talking about it. Our patients have been at the White House. There was unbelievable recognition. We did lots of publications, and donors were very interested in supporting. So back to the words I began in the beginning, which is the burden, the responsibility, the power. What we discovered was something somebody from MIT taught us, which is a learning healthcare system. It's the notion of creative tension. If you have a bold aim and you confront your realities, you can create a tension that can have remarkable impact. So Dana-Farber became a magnet institution in nursing practice and administrative practice. We became a regional collaborative powerhouse, and our outcomes in everything to do with care were consistently in the 90th percentile. 15 years later, this is the new cancer center at Dana-Farber. The fuzzy picture there over on the side is actually the pictures of all the people who worked with us on opening the building, and you can link to that. One of our payers gave us a check, our Patient and Family Advisory Councils, a check for $100,000 to acknowledge their exceptional work. We kicked off a Center for Patient Safety with a focus on patient and family-centered care. And listen, what we discovered with that participation in care by patients and families was strongly associated with not only favorable judgments in the hospital, but also reduced the risk of harm. Engaged patients have less harm, less medical error. Our practice also drove state policy. So now in Massachusetts, by law, every hospital in Massachusetts has to have a Patient and Family Advisory Council that reports to the Board of Trustees. Why? Because the public said if it's good enough for Children's and good enough for Dana-Farber and the Mass General Cancer Center, it's good enough for all the hospitals in the Commonwealth of Massachusetts. And it led some work we were talking about today, that how do organizations respond in the aftermath of adverse events. So let me end with the report I mentioned on the beginning. The Iom Report, and as a person who sits in the IOM, you can only open your mouth with evidence, p-values, peer-reviewed studies, and everything else. What the IOM said unequivocally is improved patient engagement is associated with better patient experience, better health, better quality of life, and better economic outcomes. They also reminded us that patient and family participation remains unlimited. And our closing note on this in the report is that a learning healthcare system is anchored on patient needs and perspectives and promotes the inclusion of patients, families, and other caregivers as vital members of the continuously learning community. Your strategic plan says the exact same thing as you set the agenda. for the next 5 years. One of our cancer patients, Martha Haywood, who was a long-term patient and family advisor at Dana-Farber, said, "Jim, you used to do it to me, then you did it for me, now you do it with me." I love where we are today, is how do we deliver care with patients, family, the public, and the community. And I want to end with this quote. It's a very important quote. These days, we spend a lot of time with strategies and tactics. But Avitas Donabedian, who is one of the great thinkers about healthcare quality and safety, reminded us quality improvement begins with love and vision, love of your patients, love of your work. If you begin with technique, improvement won't be achieved. What has fueled the tank of this healthcare executive since the 70s, that has developed my focus, my passion, has been the opportunity through patient and family-centered care to engage and really realize its potential. I threw in a few bibliographies. These are all hyperlinked, so if you get the slides, you can click on them and go right through them. So with that, I'll stop. I'll answer questions until the hook comes out. And so, questions, comments, reactions. There have to be some. All righty.
Hello,
Hello.
I'm a staff member here. I love my job. I love this place. I'm also a family member of an elderly mother-in-law who's been here. And I want to know how this will help her, because there have been issues, and the latest one was she's at a villa being taken care of and had to come here for dialysis. And when the dialysis was done, she was dropped off outside the villa at a locked door and fell and was left for 45 minutes before someone found her. I just want to know how to make staff everywhere care about the elderly.
Thank you. I think for all of us involved in healthcare, that is the last thing we want to have happen. What patient and family-centered care is all about is creating an environment where it's safe for you to tell your story, and the organization celebrates, devastated as they are, the opportunity to learn. What I've learned as a leader is typically when this happens, it's not about the caring of the staff. It's about our failure to put in place a system that describes exactly what that handoff has to be. So when she's brought back to the villa, it's very clear that the responsibility for care does not end until somebody else picks it up. But the gift is the gift of being able to hear stories like yours. And we talked about this a lot today with staff. Because when you develop good listening skills, as proud leaders in an organization, you are going to hear endless stories you don't want to hear. But when you hear them, and it's hard, you are given the gift of using that story to drive change and improvement. So I have no question that somebody here will will follow up with you, but it's the importance of developing this vibrant community where people are sharing their stories, whether it's the media or sharing their stories with you, because there is a belief that if shared, it will drive change and improvement, and it will allow us to put an appropriate level of burden on staff, but not hold them accountable for something that the clarity of expectation was never laid out. Thank you. Sure.
I just want to say that I did speak to someone in the renal department afterwards. They were aware of the situation and that they were looking, they had had a huddle and discussed it, and that they were going to look at the process of
Yep.
transferring patients, which really encouraged me.
Great. Thank you.
Good afternoon. It's
Good
a pleasure to meet you. I had read a lot of what you've written before, and I'm really pleased that you've made it to our community to talk to us. Something similar, but not as tragic as the case that you've just described, is happening in Ontario right now, where 1,200 patients were given diluted chemotherapy. Most of the effort in Ontario has been on the supply chain. The why did that happen? So I would like, if you have time, how did you get people to go from why did that woman get 4 times the amount of chemo and die, to how do we focus on the future to make things better? We're having a tough time in Ontario looking forward. We're looking backward as to what happened, why it happened, why is the supply chain, what should be changed. We're nowhere near what you're talking about, so any guidance for us?
So I hadn't heard about the Ontario case. So you imagine 1,000 patients who thought they were getting better, who thought the chemo was working, and now they have been thrown up in the air. What we learned, and it was trial and error, is that we had a first responsibility to the patient and family. That's why we disclosed. And then we also learned in a notion coming out of Disney that we couldn't just say, fire a few staff, rewrite a policy, and hope it didn't happen again. We had to create the wow. In service to our community, we had to restore trust. And this is all about trust. We also, as I said, the last thing our staff wanted was to hurt Betsy. They loved Betsy. So we went and studied other industries. We studied NASA and how they handled the first Challenger accent. We went into other places to learn. You know, the white paper that I showed you, put up on the screen, on respectful management of serious clinical adverse events, I think Ontario really should look at that. What we've learned is there's a series of very specific steps. The first thing you have to do is show empathy. You have to say, I'm sorry. Then the second thing is you have to provide those 1,000+ people and families support. Then the third thing you have to do is an investigation, an assessment, and then the next thing you have to do is apologize if that's appropriate, and then you go on to resolve it, and then make sure there's learning and improvement that comes out of it. It's a very reproducible series of activities, whether you're in nuclear power, aviation, or healthcare. So I'd be more than happy to talk to anybody. I was the lead author on that white paper, but there were 80 individuals and organizations around the world who worked on that, and I would really think that would be the place to go. But happy to help, and I know the community I work with would be happy to help in any way we could. Hello, sir.
Hi, good afternoon. Wow. My name is John Lindsay. I'm chair of a group here in town called Friendly to Seniors, and we've been working closely with the hospital over the past couple of years, and we have a good relationship, and I think that some of the isolated events that occur, of course, are those events that do make it to the media. And they are events from which we can all learn. But what I wanted to find out from you is that, do organizations over a period of time develop sort of a climate that is not conducive to developing these type of relationships? I can think when I was a teenager, I worked for the post office, and the post office was such a proud service at that time. You know, they would make sure that every single letter got through. And then over a period of time, something happened. And did it become too big? Did it become too lethargic? Did people not care anymore? You know, you'd throw a letter away, it seemed, you know, rather than make sure that it got to that person's. There was that sense, as you said, there was that sense almost of loving the organization, being respectful for it, and really very proud of working for it. But, you know, over a period of time, do those things occur, and then you have to reinvent? You have to look at what you're doing, because, I mean, this organization has 3,700 employees, which is, and I've been treated excellently, you know, by the staff when I've been in here for various treatments. And however, we get calls to my organization, you know, from people who say, well, that wasn't the case. This unfortunate thing happened to me. And oftentimes for the older folks, it's not people my age. I know my organization, we found out our average age the other day was 74. But
Sounds like my friends.
so this cohort is, these aren't the ones that complain. It's their relatives that really come forward.
Yeah.
But we don't know what's going to happen if the new baby boomers come up, and they're probably going to demand a lot more than perhaps my generation. But I guess my question is this really sort of a quality improvement program that needs to be reinstituted over a period of time because people forget, or are they?
Yeah, no,
That's my question.
Yeah, no, it's a great question. The risk is losing track of the aim. You know, not being mission balanced. You know, right now in the United States, the huge cry is, show me the money. There's an extraordinary focus on money. Others an extraordinary focus on strategy. Others an extraordinary focus on anything but the patient, the family, and community. So when people lose their way is when they lose that focus. And all over the world right now, I'm giving a talk in Washington a couple of weeks called The Waterfall. As I interact with people around the world, they're drowning in a waterfall of initials. Endless initiatives. There's not cascading goals, we're not prioritizing, we're not linking, and people are dying. So I think the risk that we have is only occurs when you change your aim. So an organization that was very patient and family focused refocuses on the bottom line. That's when you have a challenge. Or an organization in a competitive environment becomes refocused on who's the biggest force in the community, as opposed to how do we best meet the needs of that. So I think as long as an organization stays mission balanced on why they're here and what their service is, I don't believe they're at risk of what you talk about. But there's a tremendous amount of issues in play across the world in healthcare right now that could distract that. And it's why, again, the strategic plan is so important, because that clarity and that resolve is front and center in the strategic plan. So with that, I think it's time. It's been an honor to be here with you. Again, I congratulate you on your work, and thank you very much for your questions.